Walalani, welcome. My name's Ian Campbell from Palliative Care Australia, on the lands of the Ngunnawal and Ngambri people in Canberra. And I extend that same respect to elders past and present across Australia, connected to the various nations represented by those gathered for another PCA Connect webinar. We have over 230 people registered, tuned in this afternoon via YouTube or Facebook. Lots of people from Brisbane and Queensland joining us, and a special shout out to our viewers in Ireland and New Zealand joining our webinar today. On the agenda, apart from lunch or morning tea, depending on where you are, is the biggest health issue facing Australians over 65, dementia. There are currently 400,000 people living with dementia in Australia, and that number will more than double in the next 40 years. That increasing disease burden is also part of what is driving an increase in demand for palliative care across Australia. And we're on a trajectory to double that need by 2050. Big numbers that can be hard to relate to, but we have some great people assembled today to help us understand the human face and the actions we can take together to support people and families at the centre of this and better connect dementia care and palliative care. Let me introduce you to the people who'll be informing our conversation today. Dr. Alyssa Campbell, a geriatrician and palliative care physician working in acute geriatric medicine in Perth. She's the president of Palliative Care Western Australia and the chair of the Special Interest Group in Palliative Care for Older People with the Australia and New Zealand Society of Palliative Medicine. In 2022, Alyssa undertook the inaugural WA Health Department Churchill Fellowship to explore models of palliative care for people with dementia, visiting clinical research and community organisations in 7 countries. Thanks for your time today, Alyssa. Please welcome Jane Littledyke. Jane has been a clinical nurse consultant with the Nightingale program for 6 years and has recently moved into the team leader position of the program. She works as an independent practitioner, providing specialist palliative support to people living with advanced stages of dementia and their care partners. Thanks for your time today, Jane. And a couple of fellas who I think will be everyone's friend at the end of this. Vern Marshall. Vern started his working life as a high school teacher, but for the last 17 years of his working life was the principal policy advisor to the chief executive in the Department of Education and Child Development in South Australia. Vern is currently enjoying a busy retirement, which gives him the opportunity to serve his community in a number of ways. Vern's second wife, Rosemary, was diagnosed with early onset aggressive dementia at the age of 59. He retired early to care for her full time, which he did for 10 years, including the last 2 years. Rosemary passed in May of 2021. Vern now convenes a robust, informal group of dementia carers in the Adelaide Hills. Thanks for being here, Vern. And finally, let me introduce you to Barry Egan. Newly married, Barry went by boat to the USA in 1960. He returned to Australia in 1967 to a teaching and research position with the University of Adelaide, where he worked until 2010, finishing as Emeritus Professor and Fellow of the Academy of Science, helping raise children along the way as well. Barry's wife, Janine, was diagnosed with dementia in 2012, and Barry cared for her until she went into residential care in 2018. Janine passed away in 2021, 61 years and 1 day after their wedding day. Thank you all for being here today. It's a real privilege to share this time with you. If you've got any questions, if you're there tuned in and if you've got questions and comments along the way, please type them into the chat and we'll do our best to get to them. And today's PCA Connect webinar will also be available for you to watch later on as well. So let's get this conversation underway. Let's start at that time of diagnosis of dementia. It can be a pretty confronting time, I imagine. What happens and what should happen at that point to support people with dementia and their loved ones? Vern and Barry, let's hear from you in the first instance. What was your experience, that point of diagnosis? Tell us what happened for you guys then.
Yeah, okay. Perhaps I'll start. Look, from where I sit, I guess if the dementia journey was to be reduced to one thing, it would be stress and the management of that stress, both for the person with the diagnosis and also, and ultimately more so actually, for the carer. In most instances, it's something that we don't know much about. And so a very steep learning curve is first up. As the carer, and the person that you're caring for, depending on just where their cognition is at the particular time, as we endeavour to sort of soak up information from physicians. You might be lucky to have a really good GP in this area. Many don't. And from infrequent interactions with neurologists and or geriatricians, plus other sources as varied as books, the internet, and other disembodied sources of sometimes fairly dubious information. In terms of other sources of support, navigating this world is probably the single biggest challenge of the dementia caring journey. You may be fortunate enough to get onto a useful carers organisations such as Dementia Australia, let's give a plug where it's due, early in the journey. But for others, it is less obvious and it can take much longer. Essentially for carers, especially early in the journey, there often appears to be a plethora of seemingly overlapping and randomly distributed support services, and a maze of clinical advice of unknown reliability. There just isn't yet an idiot's guide to this new world in which one can have confidence. Rest assured that much of the time in the group that I convene is often spent assisting our new chums with this task, especially with helping them to discriminate between the more sort of altruistic organisations and those who may be well-intentioned, but in the end are offering a product for sale. Finally, unlike the specific remit of Dementia Australia, many carers organisations attempt to cover all forms of caring with common approaches. Can I say emphatically that this absolutely does not work for the unique aspects of dementia caring?
Thanks so much, Vern. Barry, what do you bring to this conversation? Do you remember that point of diagnosis for you and Janine? Can you relate to the stress that Vern points to there?
The stress I had most was with the diagnosis itself. Living with dementia, I sort of divide care of my wife into 4 stages. There was pre-diagnosis, there was post-diagnosis, which is at home, and then there was residential care, and finally end-of-life care. Now, at the beginning, when we were first diagnosed, we were just going along handling the fact that she had a memory problem, and we could reduce anything to her memory problem, and we curse it and carry on. Then she goes to have her diagnosis. Now, this was the most, in my memory, one of the most traumatic experiences that she had, because the geriatrician, he had already, in his office visit, had come to the conclusion that my wife had dementia, but wanted to get something more definite from his favourite psychologist, and so she was asked to go and have a memory test, which was 2 hours, and she finished up really a mumbling mess of trying to answer questions which he couldn't answer. But the guy was trying to get a digit, he's trying to digitise her inability so he could give it to the geriatrician.
Yeah.
I couldn't see to what advantage this benefited her. She already, after the visit to the geriatrician, he told her she had dementia, but then he gave her no other advice at all. How to handle it? You've got dementia. So that was the beginning, and we just went on with our life. And what I would say at the beginning, what saved our bacon was 2 things, was day respite and a carers group. Now, this day respite, I've come to learn, is pretty rare. But certainly for us, what it amounted to, it was a suburban home. It was run by a care organisation called Southern Cross. And it was a suburban home that was remodeled, and it had a large activity room, a small music room, a couple of bedrooms, a kitchen, things like that. And my wife would drop her off at 10 o'clock in the morning and pick her up at 3 in the afternoon. And in there, they did all their own cooking, and they prepared food, they had their lunch, they had activities, they sang, they did things, they had outings. And then I stayed with her for the first few weeks and got to understand different forms of dementia and also meet other carers. Now, that was 1 day a week. And by the time we went there for many years, and by the end of it, it came to be 6 days a week. And it freed me up things, and I also met other carers. And it was something, because I got to know other people in that group, other carer, I could talk to my wife about the various characters she met. Fantastic. And then the carers group is what Vern's spoken about. And that was a group meeting together. And because we had the common thread of caring for dementia, it really was the glue that formed that group. And you didn't have to explain yourself, even the most challenging situations. We all knew what you were talking about. And so there was a lot of giggles and laugh and relaxation. So for me, certainly in that period, before she went into residential care, that's what got us through it. It was this day respite and the availability of a carers group looking after dementia, not the general care, but dementia itself.
Barry, Vern, we're so lucky to have you part of today's conversation. Alyssa, what wisdom do you bring to the real world experiences that you've just heard from Barry and Vern? I put myself in your shoes, and I imagine you've been on the other side of that equation as a geriatrician trying to help people understand what's going on. What wisdom do you bring to those that experience of being a health professional in those early stages of a dementia diagnosis? What are the challenges that health professionals perhaps face at that time?
Yeah, and I think that thank you so much for sharing your stories, Barry and Vern. And unfortunately, that sort of trauma around the diagnosis is something that still can occur. There's often the diagnosis of dementia is made in a memory clinic, and in Australia, these are predominantly run by geriatricians. And they can vary a lot in the focus. Some of them focus very much on diagnosis and perhaps prescription of medications. And others provide ongoing care throughout the course of the illness with dementia and advanced care planning and that sort of thing along the way. And also, people can receive a diagnosis with dementia at various stages of the disease. So at some people might be quite early in the course of the illness. They might still be working, driving, have decision-making capacity for all decisions, and other people can be in quite advanced stages of the illness where they no longer have that decision-making capacity. So that creates challenges as well. And I think that one of the extremely fortunate things for me in my memory clinic and in many places is that we do have a multidisciplinary team, including social workers, occupational therapists, nurses, not just doctors, and also access to those community groups that Barry mentioned, such as Dementia Australia, or in WA, we've got Alzheimer's WA as well, where people can really get that peer support from carers who have gone through this journey themselves or are going through it at that time, and really can help educate both on the practical components of care and maybe communication skills, but also what to expect in the future, which I think as health professionals who are often pressed for time, and obviously we have different motivators for our clinic sometimes, we don't necessarily communicate this very well at all.
Jane, picking up on Alyssa's point there around communication, is that a role that Dementia Australia seeks to play? Indeed, the Nightingale program that you're a part of seeks to play. Tell us a bit about the supports the supports available in those early days of a diagnosis.
Sure. Thank you, and thank you to everyone that's spoken so far. It's been, really heartwarming to hear your stories. And so certainly Dementia Australia, who runs the Nightingale program, offer a lot of support for people in the early stages. And when we say people, we're looking at anybody impacted by dementia, whether that be the person with the diagnosis, their family, people around them, and healthcare professionals. The Nightingale program itself is really there for the later stages. So we're not so much supporting someone in that earlier diagnostic stage, but that person would be more advanced. But having said that, Dementia Australia, really is there even actually pre-diagnosis for people who have those, early concerns around changes in memory, right through to end of life in South Australia. We're very lucky. That does look slightly different in other states, but certainly there are services in every state. We're a national organisation. And look, I guess the other thing that's really running through my mind as everyone's talking is that everyone's experience is different, and where they might be, with their age, their background, their culture, so many factors can impact on how someone responds to a diagnosis or how they delivered the diagnosis or even accessing a diagnosis. We hope that people do get someone like Alyssa, and get into a memory clinic that's interdisciplinary and get that support, and then hopefully get referred into Dementia Australia from that. And they can access, the website, the helpline that's 24/7, and really get, directed into support that might be best for them. And hopefully not too overwhelming, because I know Barry and Vern touched on sometimes there's a bit of a plethora of information. You think, oh my gosh, I've just been given a diagnosis, please don't give me 6,000 handouts as well. So I think it's really about supporting people where they're at. And it might be that you're opening up the website and taking a little bit of information, getting some free resources sent out, and then stepping back in when you're ready. Hopefully, I think the other thing that's really important that Barry and Vern particularly mentioned was community and building that community. And I think that sometimes people living with dementia, sometimes there's some stigma that perhaps might be different to another diagnosis. If someone was diagnosed with cancer, they might have a different experience of community. And so I think that's something that's really important to touch on as well, and that we hope that people would reach out to those around them. I think, talking to others with shared experiences can make a big difference. And I've had a really good experience with this, or this worked for me, give them a call. And, really having a peer, and those peer connections can be vital. Dementia Australia does run a peer support program sort of formally, but those informal, community supports I think can be most important to people and that in that community.
Thanks, Jane. I'm keen to come back to that point around building community and get some advice from the Brains Trust assembled. Anyone watching, if you've got any comments or questions, please just tap them into the comments thread and we'll do our best to get to them. Barry and Vern, let's come back to you. One of the challenges that Palliative Care Australia sees is that a lot of people who get a diagnosis of dementia don't necessarily see it as a terminal diagnosis in the early days, and perhaps aren't connected to a palliative care service early on in the diagnosis. Is that something you can relate to? Were you plugged into palliative care in early on in your experience?
Yeah, look, Ian, absolutely agree with what you say. As far as palliative care is concerned, I can say with confidence that while there are exceptions, the majority of in the majority of dementia care situations, most people spend their final years in a full-time care situation, and palliative care is invariably something that is associated with the end of life experience. So that's how it's conceived. That's how the majority of people regard it. After some time in an aged care facility, something catastrophic happens in the resident's brain, and at some time, perhaps a few days or sometimes a little more, what we would recognise as palliative care generally is administered. And that happens well. In most cases, the family GP or perhaps a geriatrician is involved in prescribing the medication, and it's administered by the nursing staff of the facility, and pretty much universally it's administered respectfully and appropriately as the parent is cared for and monitored intensively over that time by staff with whom the resident and the carer know and trust well. It's very uncommon for me to hear or be made aware of any issues or complaints that folks, carers have at that particular stage of the dementia caring journey. It's sort of something that happens in a sense seamlessly and in as low-key a manner as possible. which of course is not to say that it's an easy time for carers by any means. Looking at things from their point of view, in most cases, the carers spent many years caring for their loved one with ever-growing intensity at home, and then with respite, as Barry mentioned, then invariably trying to keep up some sort of caring role in the care facility, visiting regularly, frequently, helping with feeding, trying as best possible to encourage and support residents in the sort of lifestyle activities that Barry mentioned. And the end of life palliative care experience, whilst it happens well and easily in a sense, it's traumatic for carers. Because suddenly the very practical caring involvement comes to a pretty abrupt end, really.
Yes.
Sure, you, family and friends, gather around as much as possible for those last days. You attempt to continue discourse with the patient, but basically carers suddenly feel very helpless. The care of the loved ones moves, it seems, totally into the hands of others. And for a lot of carers, that's an unusual and rather disturbing experience.
Yeah.
It's certainly true that the relational connection with physicians and nursing staff who are familiar and trusted really helps that transition for carers. And can I say that in my sort of involvement with the lead up to today's session, it has come to my attention that there is another quite different conception of the role of palliative care in the dementia caring journey. And I may have a chance to mention something about that a bit later. That may come up more, but I can see that it may profitably have a significant role to play right from the start of a dementia diagnosis.
Let's run with that point that you make beautifully, Vern, and bring Alyssa and Jane and their experience in at this point. Alyssa, starting with you and picking up on that point of the role that palliative care could play early on in a diagnosis. Vern spoke about, I guess, the role that palliative care plays towards the end of life, but based on your experience and your research, what role could palliative care play right up front, early on in the diagnosis?
Yeah, so unfortunately, I think at the moment there is very little access to palliative care at the start, at the time of diagnosis. And even the basics of palliative care, like communicating the diagnosis and providing that post-diagnostic support to patients and carers, is often lacking. And I think with palliative care for people with dementia, that it doesn't need to be an intensive specialist palliative care input throughout the course of the illness. That's not going to happen, and it's not necessary. But it's really being available at certain times throughout the course of the illness, such as at the time of diagnosis, perhaps when someone first starts needing care at home, or respite, or when they're no longer able to drive, or start having swallowing difficulties or communication difficulties. And I think that at the moment, that's not happening. And it's like Vern mentions, right at the end, when someone's at the very end of life in their last few days, it's very disruptive to then have a completely new team and new professionals coming in who don't know that person and don't have that longitudinal relationship. So with my Churchill Fellowship, looking at models of palliative care for people with dementia, because our existing models of palliative care don't fit the needs of people with dementia and their families, one of the key things is having care navigation throughout the course of the illness to help manage that plethora of services, and also just to have a single point of contact at times of need when palliative care might be required. And also, I think you've mentioned community, having a compassionate communities approach that incorporates all of the strengths that are within a community and using those to help support the person with dementia and their carer, rather than relying on the health system, which might not be what's necessary at that time.
You give me goosebumps talking about the solutions and the actions that we can take forward with government and with community. Jane, what stops us from doing palliative care better or introducing palliative care early on in the dementia journey? Palliative Care Australia and Dementia Australia have collaborated on a terrific updated policy statement that's just been uploaded to the PCA website that teases out some of these issues and points to the need for education and I guess a general awareness raising of the role that palliative care can play early on in a diagnosis. But from your perspective, what are some of the issues that get in the way of palliative care stepping in at at that earlier point?
Look, I think, if we break it down, I think first and foremost, actually having that recognition that dementia is terminal, that, that we are looking at something that is life limiting. I think even, broadly within health, actually, particularly for people that might not be, working particularly in that field, having that understanding is quite limited. I think there's still, even, within health, some misconceptions around what dementia is, what it looks like, that it's more than just memory loss, that it's actually going to, globally impact that person and everything around them and will limit their life. I mean, I reflect back starting this role when we had fourth year GP students coming in, and they would have some interesting debates with me around people don't die from dementia. And really, I think if we don't move past that real, core understanding, that we're never going to get to a point where we can actually provide that care from the beginning. And I think, again, stigma and dementia and palliative care both, can have some stigmas attached to them and barriers to talking about it. Within Dementia Australia, there's a great focus on living well, and being engaged in things, and sometimes people don't connect living well and palliative care in one. They can't see the benefit of having a palliative approach is actually, enhancing every aspect of that person's life. So I think that's a barrier. Certainly within the Nightingale program, which is just in South Australia at the moment, but is expanding, we do support people early, through that process, even us, though we don't come in right at the start. We do sort of come in, where someone's relatively advanced often, but do hope to have some of those things that Alyssa was talking around, a single point of contact, and hopefully anticipate needs and reduce some of the reactivity that's going on, and provide that education and support for families and care providers.
Barry, I'm wondering about your experience and indeed Janine's experience. Can you relate to that idea of there being stigma around dementia and palliative care? Is that something that you can relate to from the experience you've had with Janine and your family and friends?
Not really. I just want to say that for our end-of-life care, which was in the residential care, I can only say it was beautiful.
Good.
Okay? It was when they told me that my wife would be going to be palliated. It was the first time that it had ever been used and then that was in 2000, about 6 months before she died. I found it all, that end of life part was, I have great memories of it. I spent the most important thing is we had a private room, so I used to visit it all throughout her time in the residential home. I used to visit daily, and so we have a private room. We had a little cuddle couch so we could cuddle. I could talk. She's not responding. She's sedated, but nevertheless, I have a beautiful memory of when the last day that she was there, as I said, 61 years and 1 day. I visited and they just changed the linen. Her pillowcase was an apricot and was all creased, and her linen was all creased, and she looked peaceful. And then I went home. It took me 10 minutes to get home, and there's a phone call saying that she died. Now, I really have a feeling the residential home did that very well. They had a good contact with the doctor. I was aware of comfort care, and the fact is that I just wanted her, to be comfortable, and I had my own times with it. But at the beginning of the journey, we solved our own problems. The idea of being a terminal illness, I find rather threatening to even talk. We never talked about that. We just stepped into our life and we adjusted. Now we've got 50 years of doing this anyhow, but the most important thing for us was to go out every morning and have bacon and eggs for breakfast. And we'd share this, and we did it every day, and we did these routines. So we'd always have a cup of coffee in the garden during the day. You did all these things, and you don't ever talk about end of life. You're just enjoying each other. And I must admit, I wonder, how does that poor person who's got dementia hasn't got a carer? Intolerable, because I'm I'm the social navigator for my wife. I'm the intercommunicator for my wife, and all these sorts of things. She doesn't understand these things, but we still having quite an enjoyable life. And then you go into, to me, the greatest challenge is when you go into a residential home. That's where I think things really hit the wall, because it is Dullsville. No, not much joy going around, not too much laughter, unless it's created this aimless existence. So that's where I find the greatest challenge, going into residential care.
Barry, hearing you talk about the experience of you and Janine, you beautifully point to the quality of life that we all want at that stage of our life, that is really at the heart of palliative care and really at the heart of dementia care. When you talk about the bacon and eggs, the fresh linen, the cuddle couch, all those things just add up to point to quality of life that part of our conversation today. Alyssa, there is a practical element that comes with this around advanced care planning and having those conversations around what quality of life looks like to the individual and to their family. And given the nature of dementia and the different paths it can take, I imagine that for a dementia patient and their family, having those conversations early on about advanced care planning, about their wishes, is really important.
Yeah, it is, and particularly with dementia, given the nature of the illness, that people will eventually lose their capacity to make these decisions. I think in the first instance, as Barry said, it's very confronting to be told you've got a terminal illness, particularly when you're adjusting to the diagnosis and the focus is on living well. But I think that at a minimum in the beginning, we would encourage people to appoint an enduring power of attorney for finances, because that can relieve a whole lot of stress further down the track. And to start having conversations with people about what their values are and what's important to them. But to do advanced care planning well, obviously it should be an iterative process over time, but also people need to be informed about what to expect as the disease progresses. And there's a lot of, I guess, misinformation, or just it can be a complete black hole of information about what things might look like in the future with dementia. So obviously we need to have good education of people with dementia and their carers about what to expect in future, so that the advanced care planning is informed. And ideally that does involve then going on to appoint someone as a substitute decision maker, and also, if relevant, writing advanced health directives as well. Although again, that can be very challenging, particularly early on with the diagnosis, because it might be many years down the track before someone loses their decision-making capacity. And as we've mentioned, for every person with dementia, things go differently. So we don't know, someone might be affected in the way that they communicate or the way that they can mobilise, but in other ways they might be still very happy and able to have other meaningful relationships and meaningful activities in their life. And it's difficult to know, how this is going to look in, 2, 5, 10 years. So I think that's where it's important to have conversations about values and wishes early on.
We'll certainly be including links to some really handy resources within the show notes. And at the end of today's webinar, we'll be pointing you to some great resources with advanced care planning and having those conversations. Jane, these are big conversations for health professionals to have with people.
They are.
Any advice for health professionals in having these conversations with people, tackling these big subjects? Alyssa pointed to, I guess, the importance of time before, but as someone who has these conversations with people, what advice do you offer others having conversations?
Look, I think first and foremost, and I acknowledge that I have a very fortunate role in that we have sort of very continued relationships with people. For us, I think building rapport, building respect and trust, and sincere relationships with people can really, it might not be the first, second or third conversation. It might be, for some people it is. For some people you walk in and they're absolutely feeling that they really want to have those conversations. Other people, it takes a little bit of time, and we might start with, easing it in. I think and really revisiting often because things change, and really having those open conversations and framing it around empowerment, around choice, around well-being, and unfortunately the people that I support, these conversations are usually with the next of kin or family or somebody, another guardian. But certainly when I started the role, we did have capacity to help people complete advanced care directives. I did have lots of conversations with people earlier, so I'm reflecting on that. And I think, honesty is important, language is important, and culturally too, different people from different backgrounds have different relationships with death and dying that we need to be very mindful of. And I don't think that as health professionals we need to know everything about everything, but asking questions respectfully. What does this mean to you? Learning from each other and not pushing our our own personal values or opinions, but trying to give open, honest information. And letting people take time to digest it and come back to you with questions as well. I think sometimes a bit of humour is helpful, or sharing a little bit of experience, but I think it really is about that empowering people and trying to give them a voice and explain to them that this will help them have that voice when they can no longer express things articulately.
Vern, what sort of experience did you and Rosemary have around advanced care planning and talking about Rosemary's wishes for the future? What sort of experiences did you guys have?
Thanks, Ian. Look, it was, we didn't find that a huge problem. We were able to discuss those things quite early in her diagnosis, where, she did have a clear awareness, I think, of what was coming, and appreciated the need to do those sorts of things, and we were able to have some quite deep conversations about it. Ours was a second marriage, so we had children on both sides of us, and all those kinds of things, and what the future would hold for. I mean, we really did appreciate how important it was, and we were able to go to lawyers and so on who were very sympathetic and understanding and have those things. And I must say that, I guess having those things done and in order significantly reduced an element of stress that I know does affect many others who don't do that. Because one of the big problems, of course, that a lot of carers face is that there is resistance and denial on the part of the person with the diagnosis. And, that's an enormous thing to get over. And having heard many stories about that, I am just so grateful for my situation, which was so much easier. For many, it is a huge challenge and often never really gets resolved properly, and becomes a huge problem when you get down to that end of life sort of situation that we've been talking about. So again, it's a kind of mixed bag. In my personal situation, it was fine, but I know there are many others that have a very different experience.
We'll be posting some tools and resources in the show notes to help families have those conversations. Barry, I'm keen to move on to the importance of carers and the need for us all to look after fellas like you, people playing that caring role. Take us back to those days where you were playing the role of the full-time carer, and give us a sense of the shoes you walked in at that time, the pressures you felt, but also perhaps the joy and the privilege that goes with that role as well.
It's sort of hard because when you're married for quite a long time, and if your marriage is going well, caring just goes on continuously. And I, in retrospect, realised that we had a daughter who died at the age of 5.5 from a genetic disease. And she was quite normal until she was 2, but then she had a seizure. This is in America. And that turned out, no one knew, they couldn't diagnose it, but it's a thing that we now know because we've done DNA sequencing on the tissues, and it was a thing called Batten syndrome, which is a lipid storage disease of nerve cells. So my wife looked after her at home, this is at Stanford, in California. She looked after her while our daughter, day after day, just lost nervous function, ability to eat, defecate, anything you like, and she died at home. And so I feel, now coming back up to dementia, I feel I've been to hell with that experience. And all this, we just take day by day with the dementia. We just went day to day. If we needed something, well, bacon and eggs would fix it.
Yeah.
It's just a gradual development over time to do that. And I said the only jar was when she went through that experience of having the psychological testing for 2 hours and she found herself so inadequate. That was the only, I feel, hiccup. But we didn't, I knew about dementia, she didn't have to know about it. So I knew it was going to be terminal, she didn't have to know about it. Then you just live and you concentrate on, I think, on what joys come your way. You enjoy it, your ability to giggle. You take all those things. You can do all the preparation. So that's why I think it must be exquisitely difficult for that person who's got dementia that hasn't got a carer.
Yeah.
We need to know it's terminal. I don't believe that the person does. They can talk about their rights and things like that. I know my wife. I knew her very well. I know all her history. I knew all the things. I knew the advantages. For example, she used to be a very retired. She always would be at the back of photographs. She never put herself in front. Yet she was the state swimming champion for 16 years of her life. She swam with all these. She was great. But her dementia, she had loved music, and I had to put on this, go to a theatre, I'd go to the side because she'd stand up and start conducting the scream. It was quite a show off. And I loved that. But I realised that other people mightn't understand it, but I couldn't really care a stuff about it. I just enjoyed her getting up and doing all these things, which is just so not her. So there's all those. Every opportunity for a giggle, you've got to find it and take it. That's what I say.
Thanks, Barry. It's great to remember Janine and all the different facets of who she was and her life. Barry, both you and Vern have pointed to the importance of community and indeed the role that community plays in supporting the carer. And Vern, I wonder if there's perhaps some advice you can share for the community around engaging with carers and around engaging with people who have dementia. We've touched on the stigma there is around dementia, and a lot of people are nervous or apprehensive around engaging with carers or engaging with people who have dementia. What advice do you have, Vern, around talking to people with dementia, engaging with people with dementia as you go down the street, as you go down the shops? What advice do you have?
Sure. Well, I mean, I guess basically it is important to engage as you can. That is one of the biggest issues for carers in particular. I think there's two main challenges that carers, people who are caring for someone with dementia face. Because let's face it, people who are caring for someone with dementia are living with dementia, and somebody else, but they're living with it very closely. There are two big challenges. One of them is that you end up caring for somebody over time that you very much no longer recognise. It's not the person that you knew through your life. Their behaviours, their changes, their attitudes can change, sometimes very significantly, sometimes just a little along the way. But the other big challenge really is what you were talking about, that there is a great deal of aloneness. It's a very lonely place because other people, folk in the community, friends, and even often it can be your own family, begin to distance themselves. So you do feel very alone, and people find it hard to face those sort of things because, is this how I'm going to be? This is confronting. Am I looking at something that I might be in 10 years' time and I don't want to see it? And the other thing is they just don't know how to go about doing it. How can I communicate What should I be talking about? What do they understand and what don't they? And look, I mean, the best way really to overcome those things is to engage with the carers about and watch what they do, how they behave, take a lead from them. And then these things can happen quite easily, really. It's not difficult to communicate with folk who are living with dementia. It's just different. You have to put that into their world. And that's a thing to do. But as you watch the carers do that, so it must become, I think, easier, hopefully, for others to do that. There are certainly things in the community in general, and Dementia Australia have a very robust program of that, which encourages enterprises to become rather more dementia friendly in the way that they organise themselves and set out their environments. All those sorts of things can be very helpful, and especially, I think, thinking of the sort of people that Barry thinks about who are often alone and in early stages where they still get around. Less of a problem, perhaps, for the likes of Barry and I, who would go out with our partners and we would look out for them. We would, in those environments. But again, thinking about those for whom that doesn't happen, then that's sort of reaching out to the community and perhaps just telling them, showing them some of the ways in which it's still possible to look out for these people, to recognise that they're still human beings that require the very best interaction that is possible to give them.
Alyssa, you've got a global view of some of the issues and some of the solutions we've been talking about. Your Churchill Fellowship has given you a terrific worldwide view. You've been exploring the models of palliative care for people with dementia, visiting clinical, research and community organisations in 7 different countries. What can we learn from other countries, from other communities? What did you see that we could bring here to Australia?
Well, I think we really need to work with the strengths of what we have here to determine the models of care and whether that best fits within a palliative care framework and palliative care services, whether that best fits within dementia care, aged care, primary care. It really depends on what's already available and what the skills and attitudes are in the existing services as well. So I think we need to really look at strengths as well as where the needs are. And I have a whole list of different recommendations, but the things I mentioned previously, like care navigation, I think is really key. Early advanced care planning, public health initiatives, just again, raising awareness that dementia is a life-limiting illness, that it is a leading cause of death in Australia, and that it's affecting, more and more of us every year. So I think that in different countries, different models worked or perhaps didn't work. And I think it's up to us to look at what's already going on locally to determine the best model for Australia. So sorry, no easy answer.
There's a great brains trust assembled on the screen, but also there's a great brains trust assembled in the audience. We've had over 230 registrations watching via Facebook and YouTube. If there are any questions or comments out there, we've got another 5-10 minutes together. Please just tap those questions in the comments box and we'll do our best to get to them. Jane, there's a real joy and love that comes from you about your work in palliative care, about your work in dementia. But we have a real issue around attracting people to dementia care, to aged care, to palliative care. What would you say to young nurses, young doctors, young allied health professionals about getting involved in this part of the health sector and doing some training and taking on this work?
Yeah, absolutely. And yeah, you're quite right. I love my job. I'm very privileged. I'm incredibly fortunate to work in the area that I do. And yeah, interesting. I reflect, 20 years ago, being offered graduate nurse programs in ICU and turning them down, to work in the repat and the reactions of people around me that, oh my goodness, what are you doing? You're clever, go in ICU. And I was like, no, I had worked in residential care while I was training and I just fell in love with it. It's incredibly rewarding. And you meet beautiful people like Barry and Vern, every day. And sometimes, look, it's got its ups and downs. I certainly not in a role to support someone, through a cure at this point in time, or things don't get better, unfortunately. But it's those small wins. It can be a small improvement in someone's life, or being a trusted person in someone's life, that someone will pick up the phone and call you, and that you can offer something of, I might not be able to resolve it or fix it, but I can actually, work around. And I guess particularly the last 6 years working community has really been pivotal for me in my career, and the connections that you make with people when you're in their own homes, when you're in their space, when you're walking alongside them, are just, I've still got in contact with people that, their partner might have died years ago, but they still will reach out. They're just really life-changing relationships with people. I think it's incredibly rewarding. It's incredibly challenging. There's so much to learn. Everybody's experience is different. And I would encourage anyone, with any interest in this area to please come in and also look. It doesn't matter what area of nursing or allied health you go into, you will inevitably, unless it's paediatrics, probably care for people living with dementia or impacted by dementia in their daily life, whether you're in surgical, medical, ICU, wherever. This isn't just isolated to people, in a certain group. My youngest person that I'm supporting is 35. We are just, it's so important. And the leading cause of death in this country, we all have a role to play. And, I can sincerely say this is, the most rewarding position I've ever had in my life. And I can't foresee doing anything differently.
Thanks so much, Jane. Look, my apologies to the audience. I've had some trouble getting the comments and questions coming through, and they're just coming through now. Barry, Vern, I imagine there were some special people along the way for you that really helped at some key moments. What are some of the things that health professionals or indeed the community did for you guys when you were playing that carer role?
Well, out of very early, just very early in our journey, I guess, this woman appeared and introduced herself as she was a support worker, and just said that she'd heard that I was caring for a person with dementia. And so she belonged to a local care organisation, and she said, invited me to come and join their group, and it was a social group, but she also had visiting speakers, so it was very educative. But the biggest thing she did was meant that she introduced us to other carers. And then later on, she told me about the availability of this day respite, and I was very reluctant to go. And she said, she more or less pushed me through the door and said, go and stay with her. And so I did. I stayed the first day, and I found it quite, day respite was from 10 to 3, and so I went in there, and I went back the next week and found I was quite enjoying it. But it was very pertinent in that I got to know the characters in this in this day respite, and realised that every one of them was so different that you got to know them as characters. And then I had something to talk to my wife when we went home, and we talked about these things. So it's this woman who introduced me to those things, and it so happens that they lost funding because the government changed the way they're going to fund all these things, and so her organisation went out of existence in that way. But I've actually employed her now. She's a carer for my granddaughter who's got this mental disability. So we've been together now for nearly 10 years, and she's probably the most important person in my life. And she started out as a support worker. How the hell she knew that I existed, I don't know. But I would think it would be the most pivotal thing is that those people who have diagnoses, do they know about Alzheimer's, Dementia Australia? How does Dementia Australia know about them? And so what I would argue is that maybe as a part of diagnosis, the geriatrician should automatically notify a body like Dementia Australia about the existence of this person I've just diagnosed, and then take on all the care coordination and the controls introduced into carers group. To me, it seems, that'd be one suggestion I'd make. That was the most important person in my existence.
can I just say through that, I mean, I'd endorse what Barry's saying, that it really is important that carers take some initiative as much as they can to find out, where the real support is. Local carer support groups are really important, and there are not enough of them. We can't get our profile up enough. But if you speak to the 60 odd people that I have on my group email list, they'll tell you it's the most important thing, is that grassroots support. And it's really important to get that sort of message out. And I know so often I hear from people who get in touch with my group, with Dementia Australia, too late, too far down the track, when the stresses are already getting to them. And it's particularly difficult for men. Men have a particular problem with this. They hang on, they won't ask for help until it's too late. And I often, very distressing, speak to men who feel that they are on the cusp of doing something that, awful, that they don't want to face. So it really, really is important to promote the existence of what assistance and support there is out there.
A great word to close on, Vern. Thank you to you and Barry for being here today. And look, indeed, we've been talking about some big, heavy things. And if our conversation has stirred emotions and feelings for people, please reach out to your networks, whether they're your friends and family, or whether it's those more formal counselling networks that are out there. Lifeline, indeed, Dementia Australia has a terrific phone number, and look, we'll post those contact details, those support services, with the show notes at the end of our broadcast today. Thank you so much for your time and interest here this afternoon. Thank you to you, Alyssa, Jane, Vern and Barry, of course, for sharing your work and wisdom with us today. It's a real privilege to spend this time with you and elevate these issues and elevate the actions that you've put forward. Today's PCA Connect webinar will be available to watch again soon and share with others. And I'm really grateful for all the comments and questions that have been coming through. I'm sorry about the technical glitches at my end to see those questions a bit earlier, but we'll do our best to provide answers where we can. And indeed, check out the joint policy statement that Palliative Care Australia and Dementia Australia have worked on. It covers many of these issues and indeed point to some of the actions that the government and community can take. And indeed, that joint policy statement may well help with your own advocacy at that local, state and national level as well. This is a hard road to travel, but one that more Australians will travel in the coming decades, and our collective efforts and awareness will only strengthen the supports available. If you've got any feedback on today's webinar or subject ideas for future webinars, please let us know. And if you'd like to support the work of Palliative Care Australia, you can make a donation through our website. Take care. Thanks so much for what you do and taking time this afternoon. And go the Matildas! Ta-da.
Agreed, yes.